Fun fact about me is I have no chill when something piques my interest. And about a year ago, I tried to figure out how to be less awful at putting NG tubes, because as a rapid response nurse, when we get called for help with those sort of insertions, it's because at least 2 people have already tried. This is not going to be an easy in, and especially on night shift, we're kind of like the last option, and these folks need an NG tube at this point in the time because they're probably miserable or they're going to decompensate if they don't have it. So what I hate is to be asked for help and then not be able to supply that help. It drives me up a wall. So I did a deep dive and found some random 2006 journal article in some anesthesiology journal that had the answer to all of my problems. I have used this technique for the last year. I've shown multiple other nurses this technique, and now they swear by it too. I have such a crazy high, like, one-shot success rate, and it's dumb how easy this is, and I don't know why we weren't taught this in nursing school, because 2008, I wasn't anywhere near nursing school at that point. I was doing my first career. 2008, I was just graduating high school. So I'm going to tell you, and this is going to change so much of your practice. All right, hold on. All right, I had to figure out where to put you. I don't have like fancy equipment to put you places. You're on the dashboard. Okay. So the trick is that you need to move all of the anatomy that's stopping the tube from descending out of the way. And you can do that by doing a lateral neck press. But we don't do that as nursing staff because there's lots of sensitive things here, and you don't want to be the reason that gets shoved in the wrong direction, or you knock something loose, or you occlude anything. Don't be pushing on people's necks, all right? What you need to do to accomplish that goal, though, is simply have them turn their head and then have them leave it there during the placement. So they don't have to like chin to shoulder by any means. And it can be left or right, whatever's most comfortable for them. Ask them to turn their head into a position that they can maintain for the next couple of minutes, right? And then it doesn't matter which nostril, does not matter. So they turn their head and you pick your favorite. I always ask if they've ever broken their nose before. If they've got some sort of known deviated septum, you can look up there and see that like one side's smaller than the other. That's not your friend. Go with the bigger side first, obviously. But if several other attempts have already been made and they've already got like a bloody nose or trauma or whatever, you know your patient better than I do. I don't know who the hell we're talking about specifically. Turn their head, have them hold it there. I don't even have to have them drink water during this, but you can do the whole like water with a little straw situation, but so many of these patients have aspiration risks that I see. So again, I don't use the water trick unless I have to. So head turned, keep it there. And then when you're accessing them, you go in flat, like 0 degree. Don't angle it up, don't angle it down. None of this trying to find the correct angle without knowing what you're doing in terms of like accessing. Just straight, flat, straight, access. And I do have them swallow once I start descending. So the water can be helpful if they're having like follow through issues, but, and you just glide it in. You'll hit just a slight amount of resistance as you hit the back of the sinus cavity. But when it starts to slide, it's going to pass by the gag reflex and the whole back of the throat. Because you're not triggering the gag reflex because it's been moved with this lateral maneuver, they shouldn't like suddenly have their tongue in the back bump up, which is usually what starts the coiling process and exits out the mouth. And you should be able to just thread that sucker. Make sure you've lubed it up really good and just go for it. Nice and gentle, smooth and easy movements. Don't like jam it in there. If you hit resistance and a little bit of additional further pressure doesn't help glide it down the anatomy, don't force it. Try the other nose. But just have them maintain this turned position, and it should provide that lateral pressure that sweeps the anatomy out of the way that would otherwise like cause trouble. The study that did this, it was like a 30-patient study, and they used it on people who they were already going to be intubating for surgical procedure. So they would sedate them, put a camera up one nostril, and then try to do standard practice for placing NG tubes, and they could watch where the hang-ups were. And then what they did was they turned the patient's heads, and then they put the camera back in, and they were able to reattempt with this just simple flat approach, and they were able to watch it just fall right into place. Fantastic. Highly recommend. Next time you put an NG tube in, try this. I don't do the chin to chest anymore. I just have them turn and maintain this turned position until it's fully placed. I've had 2 different gentlemen shake my hand afterwards because it was such a smooth placement, which I never in my life thought anybody would like thank me for just shoving a thing in their face. But there you go. That's the NG tube trick, and I hope it serves you well. Please let me know if you have any different ways of doing it. Obviously, there's like the cold water stuff, and there's other little like tips and tricks for additional need, but I don't need any of them anymore now that I use this positioning situation. So hope it helps. Have a great shift.